Let's move on just to talk briefly, maybe take 5 minutes. I think on topic A, we've kind of hinted at it, immunotherapy for triple negative. And I think that triple negative breast cancer, is it going to be as good as it is for now for our colleagues in the melanoma and lung fields, or no?
Probably not.
As it stands now. Let's caveat, as immunotherapy stands now.
If you look at the predictive biomarkers for the way these checkpoint inhibitors work, PD-1 and PD-L1 may not be the panacea. The best data, to my knowledge, are the mutational load, and if you look at the TCGA data, it's very clear that breast is not one of the most mutated tumors. It's not a hypermutator. There may be some hypermutators there. We have to find them. Then you look at melanoma, small cell, bladder, non-small cell. Those are the ones that are encumbered by a lot of alterations, give you that broad neoantigen expression that is a marker for the fact that they may be sensitive to these checkpoint inhibitors. So it doesn't mean to say that there's not a subgroup of patients with breast cancer that should respond to this. We just have to find them. I don't anticipate it's going to be as good as in melanoma or non-small cell lung cancer or bladder cancer.
Right. So is there any way to make it better, though? I mean, I think that, could we increase somehow the microenvironment? I know, from example, from your institution, there are colleagues exploiting MEK inhibitors to somehow improve MHC expression, PD-L1 expression. So I mean, is that a possibility?
It is. There are several approaches. One is, key to me, is identify that predictive biomarker that gives you some odds of benefit to these therapies. Second, move it to the micrometastatic setting. Those patients have residual disease after neoadjuvant therapy, where the standard of care may be observation, and then you can deploy them in that setting. And the other one would be rational combinations with molecularly targeted therapies, but again, for which we don't have a lot of mechanistic data of what are the ones. It could be that some of these molecularly targeted therapies inhibit the action of these checkpoint inhibitors.
Right. So what's been interesting in the molecular sort of targeted realm to date is when there's an identifiable mutation, those patients don't tend to have as degree of heterogeneity and mutational load. So I'm looking at EGFR mutation positive breast cancer or ALK mutation positive, where they don't drive as big a benefit from immunotherapy. So it's really that sort of dirty, complex disease like triple negative breast cancer, which is really struck for it. So
what is the right head and neck or whatever? Right.
Yeah. So what is the right combination? So I think probably the most interesting data in this field is the combination of nab-paclitaxel plus the checkpoint inhibitors with Sylvia Adams. I think she presented that at
atezolizumab, yes.
And there's another updated abstract here.
That's right, where you're seeing a response rate in the 70% plus range in the combination. So I think it may well be that you need that chemotherapy to create that potentiation of immune effect, right, from the or activation of immune respect that could be then potentiated by this checkpoint inhibitor. So I think that combination will likely be very, very interesting. And there is so many planned neoadjuvant, adjuvant trials where we are waiting for some of this direction to say it should be all comers or should be in a defined subtype or biomarker enriched subtype that we can really see which patients are going to get the benefit.